views and opinions expressed in this program are those of the participants and do not necessarily reflect the views of BronxNet or the program underwriters.
Alrighty, that was great. Welcome, I'm the Dr. Bob Lee, and welcome to the Visiting Nurse Service of New York, Project Hope, Physicians and Health Leaders Summit, caring for communities of color and other vulnerable communities in a global pandemic. Lessons from the front line. Communities of color are being hit disproportionately hard by COVID-19. Public health experts say focusing on these disparities is crucial for helping communities respond to the virus effectively, so everyone is safer. Essentially, our country and the world are in this fight together, and it's essential to understand that the health of all of us depends on the health of each of us. Andrea Castellanos is the Executive Vice President and Chief of Provider Services for the Visiting Nurse Services of New York. And she is responsible for oversight of all initiatives related to provider services. She leads VNSNY Home Care, VNSNY Hospice and Palliative Care, Partners in Care and Community Mental Health Services, as well as the Population Health and Business Development divisions. Please welcome Andrea Castellanos.
Hi, good morning, everyone, and thank you for all being part of our summit today. I'd like to extend a huge thanks to Dr. Bob Lee for emceeing this event. Dr. Bob is the Community Affairs Director for WBLS 107.5 FM and is a tremendous advocate for the community. He also has significant on-air roles at the station. Bob, thanks for extending both your community voice and your beautiful speaking voice to this important summit this morning.
Thank you.
Visiting Nurse Service of New York is extremely thankful to our distinguished panel for joining us and sharing their insights on this critically important topic. Our panel represents the very best of New York City's frontline physician leaders, whose mission has always been to care for minority and vulnerable populations. COVID-19 has magnified and amplified health disparities across the nation. Our panel will share experiences, successes, struggles, challenges, and hopes for the future. Visiting Nurse Service of New York values our active partnership with all the groups represented on our panel today. We're at a watershed moment in this country. COVID-19 has made disparities so painfully apparent that they have become impossible to ignore. We need an all hands on deck, multidisciplinary approach to tackle disparities at every level of society. The issue of health disparities is a matter of our collective will. We know it's possible to effectively engage and support the health of underserved communities. Each of the institutions represented by today's panelists have carried out innovative, groundbreaking outreach programs that have produced real results in our community. But it is simply not enough. Change must be systemic, intentional, deliberate, funded, and legislatively supported. It's not an easy goal, but it is within our reach. We hope today's summit will be a call to collective action. It's now my pleasure to introduce Michelle Drayton, Director of Visiting Nurse Service of New York's Hospice Project Hope. I want to thank Michelle for organizing this important event. Project Hope is an example of what is possible when our communities collaborate. Michelle, take it away.
Thank you, Andrea. and welcome to all of you joining us today. My name is Michelle Drayton, and I am the director for VNSNY's Hospice Access and the HOPE program, which is dedicated to addressing the underutilization of end-of-life care and hospice among African Americans and Latinos in Harlem and the Bronx. As a result of the work achieved in the HOPE project, we are pleased to bring you this summit on caring for vulnerable and communities of color in a global pandemic. The COVID-19 pandemic continues to test our humanity and collective will. Over 6 million Americans have been infected with the deadly virus, and more than 190,000 people have died. New York City has had 447,000 cases with over 32,000 deaths in just 7 to 8 month period. This pandemic has put a spotlight on many deeply rooted problems and weaknesses in our society, including disparities in health among communities of color. This disease is killing vulnerable populations, specifically those who are Black and or Latino, at 2 to 3 times the rate of other groups. Healthcare disparities are widely documented for African Americans and Latinos compared to whites across a range of diseases, including cancer, cardiovascular disease, and correlate to problems with deficiencies in prevention, early diagnosis, and curative treatment. Ethnic disparities even exist in access to palliative and hospice care, which provides compassionate comfort care for people who are terminally ill in their own home. This pandemic has put a strain on our healthcare system and in our daily lives in ways we never anticipated or experienced. Now more than ever, we must work together to promote quality healthcare for everyone. Our objective for this summit is to engage in dialogue led by some of New York City's top healthcare leaders and clinicians about lessons learned in providing care to vulnerable communities and communities of color. Today, we invite you to discuss the disparities in the incidence and prevalence of COVID-19 among Black and Latino communities and examine their root causes. Discuss lessons learned in combating COVID-19 and dialogue about the role of home care in promoting health and addressing disparities in health outcomes among vulnerable communities. We ask you today to join in our call to action regarding increasing access to quality care and health services for communities of color and other vulnerable populations. I want to give a special thank you to the Mother Cabrini Foundation, whose generous support allowed us to expand the HOPE program. I want to thank Congressman Adriano Espaillat for his partnership and all of our panelists today. We encourage you to ask questions, get involved, enjoy the discussion, and now back to Dr. Bob Lee with some more facts and our distinguished panel.
Thank you very much, Michelle. You know, nationally, African-American deaths from COVID-19 are nearly 2 times greater than would be expected based on their share of the population. In 4 states, the rate is 3 times greater. In 42 states, plus Washington, D.C., Hispanics, Latinos make up a greater share of confirmed cases than their share of the population. In 8 states, it's more than 4 times greater. White deaths from COVID-19 are lower than their share of the population in 37 states and in Washington, D.C., the District of Columbia. To answer these questions and to talk more about the differences in healthcare and the outcomes among communities of color, particularly African-American and Latinos, are some of New York's top healthcare experts who represent some of New York's largest healthcare systems and home care organizations. Dr. Jacqueline Delmont, MD, she has led the charge at Somos, a nonprofit network of 2,500 independent doctors, to ramp up COVID-19 testing in underserved communities across the city. The native of Venezuela has worked with churches, government officials, Latin American consulates, first responders, hospitals, and private organizations to set up more than 50 testing sites. Under Delmont, Somos has helped the physicians' practices in its network access federal disaster relief. It encouraged them to look for inefficiencies and embrace telemedicine, among other steps to boost competitiveness and patient access. Dr. Rochelle Dignam, MD. She's the Chief Medical Officer for VNSNY Provider Services and also serves as Hospice Medical Director for VNSNY Hospice and Palliative Care. With more than 2 decades of experience as a geriatrician and hospice specialist, she has played a key leadership role during the current COVID-19 pandemic, helped to develop clinical protocols for the organization, and keeping staff updated on measures for avoiding exposure to the coronavirus. Asilma Ferguson, MD, known as Dr. Icy, she's not really icy, she's warm at heart, and she's an associate professor of medicine and director of cardiovascular disparities at Mount Sinai Medical Center in New York City. She's previously served as chief of the division of cardiology at Harlem Hospital Center. Her undergraduate and graduate education were at Bernard College, Columbia University, and SUNY Downstate. She completed her residency and chief residency at Albert Einstein Medical Center. Dr. Ferguson also completed a cardiology fellowship at Weill Cornell Medical Center. She is board certified in internal medicine and cardiology. Dr. Cardinal B. Smith, MD, PhD, also known as Cardi B. Okay, Cardi B. Smith. She's an associate professor of medicine in the division of hematology and medical oncology and the Brooksdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai and the Director of Quality for Cancer Services at Mount Sinai Health System. She is a clinician investigator whose research interests include evaluating treatment disparities in cancer care, evaluating determinants of cancer patients' quality of care, characterizing barriers to optimal cancer and palliative care, and developing approaches to eliminating those barriers among racial and ethnic minorities. Dr. Maurice Wright, he's the Chief Medical Officer for the New York City Health and Hospitals, Harlem Hospital, and Senior Associate Dean of Columbia University. Now, Dr. Wright has led efforts to redesign the healthcare system at Harlem Hospital to ensure greater quality and access for the Harlem community. He is a public health advocate and an award-winning physician. There you have it. We welcome you all to the panel. First question, Dr. Delmont, what is causing such high rates of COVID-19 disease and deaths in the African American and Latino communities?
Good morning, everyone. Thank you to VNSNY and to my co-panelists for the opportunity to participate in this summit. During the presentation earlier, you highlighted some of that data, but I'll expand a little bit. Somos, as you mentioned, is a group of independent physicians that have been taking care of almost 1 million Medicaid lives in 4 of the 5 boroughs in New York City and also in Nassau County. Immediately when COVID began in New York, around the beginning of March, we realized that many of the decisions being made in terms of testing were really not addressing our communities. And it's usually when you have public health initiatives, they're designed to address the totality of the population. And this is where our communities tend to suffer because there may not be as much cultural sensitivity in people designing these, public health initiatives. So we immediately realized that even though the testing sites in the Bronx and in Aqueduct, which were the first ones, were magnificent, prior to that, we said our patients are not going to be able to get to these sites because they don't drive.
Yeah. And
so we designed these testing sites that were embedded in the community. We collaborated with our other community leaders, and in the back of parking lots in churches, at schools, we brought it to the center of our communities. Now, in terms of answering your question, there are multiple reasons for this disparity. One, of course, economic and social circumstances. Our communities have lower income. They have limited ability to absorb the economic decline. They had a greater exposure because they couldn't stop working. Many of our patients are essential workers and were exposed during those months of March and April. They live in densely populated areas and therefore also have greater exposure. And then we have the digital divide. It may not be connected necessarily to all the information that is out there, to Twitter, to all social media. They may not have internet, and the media, to be truthful, alarmed everybody, but did not inform and did not pivot back to preventive measures and to encouraging a tighter relationship with their primary care doctor. We were telling people to stay home, but really didn't give them the resources to make decisions when they were ill. They were not prepared with technology to be able to communicate with their doctors and for doctors to feel comfortable to monitor patients while they were staying at home, because the traditional way of providing care is really face-to-face. And they could not go to the emergency room because we were trying to, the emergency rooms were packed, and they couldn't access their physicians. And on top of that, they couldn't communicate with their physicians. So I already mentioned access to testing. We've lived the limitations to language barriers and had to assist many times patients, even though there was free testing, they didn't know how to access links and how to complete forms. There's a lot of implicit bias from the healthcare system, and there's a distrust. Can an immigrant that is illegal in the United States get tested for free?
Yeah.
And finally, we have the underlying healthcare conditions that our patients have. We know that our patients are sicker. They have greater incidence of diabetes and hypertension, of malignancies. They're taking immunosuppressive therapy that predisposes them for severe forms of COVID-19. And, we've talked a lot about statistics, but there's a group called the APM Research Lab that reveal this statistic very clearly. They say if African-American and Latino had the same mortality rates that the general population, we probably would have saved 17,000 African-American lives and about 5,000 Hispanic American lives. Yes. So I guess that summarizes for me why our communities are at a greater exposure. And in reality, when we design programs, hopefully we never have pandemics like this, but when we decide programs that we connect with the communities that we serve and don't plan it the way that maybe I can have access as a professional, even though I may be from an underserved community or background, but that I shouldn't design it for me. I should design it for the ultimate user that are our patients.
So what are some of the lessons learned that you can share with our providers and patients in the face of this pandemic?
Well, we I think as business owners, and I'm speaking on behalf of the independent practitioners, we have to have a much closer relationship. HIPAA has made it very difficult for us to communicate with patients for the right reasons. They have tried to protect patient information, but they have limited automating and streamlining communication with our patients. There have been some waivers to communication, but I think that needs to be worked on, and we should have much better registries and capture preferred ways of communication with our patients. We need to understand what resources do they have at home. And this is valid for pandemic and for any chronic disease. What type of technology do our patients have? We're treating hypertension and we're treating diabetes, and many times they don't have equipment at home. And similarly, we're trying to keep somebody that we don't know if they have a low pulse ox or not at home without the right technology. So I think we need to assess those. How do we care for them when they're in the office, but how do we care for them when they're at home? That to me is one of the biggest barriers that we've encountered as caring for our patients.
Thank you, Doctor. Dr. Fergus, what is your perspective regarding the disparate rates of COVID-19 in Black and Brown communities?
Yes, good morning. I think I was muted, but first let me say thank you for having me on this distinguished panel. It's my absolute delight to be here to talk about, items or agenda items that are so close to my heart. And as you know, I'm the director of Cardiovascular Disparities at Mount Sinai. So I think Dr. Jacqueline Delmont basically covered many of the things that I would like to reiterate. But as you always hear, people tend to retain 10% of things when they hear it the first time. So if they hear some of it over and over again, then it creates an indelible impact on them. So let me just say, I would like to, the way I separate it, Bob, is into the disease model and the socioeconomic or social determinants of health components. And you've heard a little bit of both. But let me focus on the disease conditions first, and then I could, sort of reiterate some of what, or build on some of what Dr. Delmont focused on. So when you look at Black and Brown communities, to begin with, they suffer at extraordinary rates, all of the chronic conditions, all of them. But particular to COVID, there are certain conditions that were found to be more, have people be more susceptible in terms of predicting whether or not they would have poor outcomes. Studies that have been done in Wuhan, China, in the earlier parts of the disease process, when they looked at the retrospective analyses of people who have succumbed, or the pathological specimens, they found that 70% of the people who actually passed away had hypertension. Subsequent studies here in the United States have corroborated that, as well as have shown that the predictors tend to be cardiovascular, comorbidities, so to speak, such as diabetes, obesity, respiratory diseases, and renal dysfunction. I tell you that all of these chronic comorbidities actually lead the pack for pretty much any disease condition that you could think of. So in the United States, you have 1 in 2 African Americans by the time they get to the age of 50 that have a diagnosis of hypertension, either recognized or not. So you already have over 90 million people here in the United States with hypertension. And remember, that was one of the things they focused on. Issues related to being overweight. They've done a number of studies now that shows that people with increased weight do not do as well. Diabetes, so what happens, the coronavirus creates an inflammatory disease process. And this inflammatory process sort of revs up every other chronic conditions that you have, and so makes them worse. And then on top of that, you have the embolic or clots that develop within this whole milieu that makes things worse. So it enhances all of these chronic conditions and lead to issues. So building on what Dr. Delmont talked about, when you look at awareness, treatment, and prevention, let's just focus on hypertension. Blacks, Hispanics, and whites are equally aware, that hypertension is an issue. But when you look to actually control of hypertension, Blacks and Hispanics are less likely to have a controlled blood pressure. So already they started out with the disparities that then, basically, causes us to roll downhill with this disease process. We don't have, access, as was mentioned, the distrust that was mentioned, but also some of the medications, the best drugs are not affordable. And so because of that, that leads to a disparity going in with all of these numbers not being controlled, Then the social, determinants of health were very nicely outlined. I do want to just highlight 1 or 2 components. The distrust factor, may have stemmed, for instance, Bob, from the Tuskegee Institute trial way back with looking at syphilis and Black men. So, if you don't have, the right discussion with your patient, or people are not trusting, a lot of them think that, things are experimental or not true. And I could tell you that early on in the pandemic, and I myself was wondering if this was true or not, the word on the street was that Blacks and Hispanics do not get COVID. It's not our disease process. They're not gonna, pay heed. So part of what happened, it's not all, but part was that people had a sort of delayed response to being, adequately prepared and protected against this disease process. And then, of course, you heard with the testing, there was, lack of access to testing. Now I can say that, testing is widely available. For instance, at Mount Sinai, someone can come in the morning and get a rapid testing and know their answer in a couple of hours. But of course, I submit to you that those who are more wealthy and obviously have more resources, they're aware of this, and then they're able to get their testing and appropriately take care of themselves. So that's just sort of building on, sort of what Dr. Delmont says, but there's an opportunity for improvement.
Doctor, thank you so much. The COVID-19 pandemic created a tremendous strain on the healthcare system in New York City and perhaps shed a light on problems that existed before the pandemic. Dr. Wright, as the Chief Medical Officer of Harlem Hospital, please share your perspective.
Good morning to all our viewers, esteemed guests, and colleagues here. And Bob, thanks for doing us a great job this morning. It is truly a time when we reflect on the system. We reflect back to March 16th, the day when I first encountered this pandemic here at the hospital. And this community, I can tell you 6 months later, had significant losses amongst our community residents. We saw lives of those who survived change, and then families who had to cope with losses or with the grief process, not being able first to visit their relatives in the hospital, and then having to go through the ultimate loss and grief process, really suffered. The impact was significant. I watched the hospital change from one where we welcomed everyone into pretty much one where we had to try to protect all that could become exposed on the campus. And you can just imagine for us, in a community where we are pretty much at times dealing with the highest prevalence of these chronic diseases that Dr. Ferguson just spoke about, and how much we saw it firsthand. All the chronic diseases showed up. Hypertension, like Dr. Ferguson said, was our biggest one. But the other thing we noticed is that those who had more than one of these chronic diseases suffered the most, and lives lost was amongst those, in addition to being elderly. We, in the early part, was looking for information wherever we could get it. So to help the community, to help ourselves deal with it, we looked to all those who had gone before us in seeing the pandemic to see if there was any literature coming out, any advice coming out. And early on, there was very little. So we felt like, we were doing the things that we had to save lives. We were putting folks on respirators. We were doing whatever it took without much guidance at first. But we significantly altered the way we did things over time. And we watched as we came down, I'd say somewhere around May, a much better outcome compared to the original probably 3 to 4 weeks. So it did have a huge impact on this community, and still does, by the way. But I think that we as healthcare workers now know much more about the pandemic, the disease itself. And as again, you heard some of the things that are helping us, which was mentioned, are in full utilization here.
How has the Harlem community fared in the pandemic?
I'll tell you, when you look at African Americans with multiple chronic diseases, from one to much more at times, we have about 56% of the population here. And the ultimate mortality was at about 62% for African Americans. Hispanics, who have about 23% in the population, had the largest disparity here. They suffered about 34% of the mortalities, and the hospitalizations, by the way, were in line with this. The community on a whole, because again of the many chronic diseases, even in younger patients, we saw much more of the individuals that originally we didn't see in the middle and towards the end coming in. And so this community has really taken a big hit, and it continues to take a big hit, although at a much lower rate. And I believe that overall, if you look at the patients who are coming in now, the fear that went through this community is keeping folks away from care that they desperately need. So that we are afraid could have a large impact in months to come.
Yeah. What are your plans for the future, particularly as we face the flu season?
Probably the first and foremost, a little bit of a selfish act here, but is to get everybody immunized for the flu. If I can eliminate some of the flu patients showing up and keep it in an area whereby we can say it's at a low rate in this community, we'll be doing very good. So that's the first on the agenda, to get the flu vaccinations done widely, get as many patients and for me, staff also vaccinated to keep the flu at bay. But there are other things that we are looking at. We are much better equipped. We are much more knowledgeable. We now know that ventilators, for example, is the ultimate last choice. We have other choices that we do early on to prevent that ultimate last step. We are really ramping up testing and contact tracing. We have a testing center here, which is open to the public, not as fast as Dr. Ferguson's system, but it's pretty fast, I'd say. It's within a day and a half, so I'm very happy for that. And inside the hospital, I can get it rapidly. The emergency plans that we have for mobilizing the staff that may be necessary again. One of the big things we found out is that if we can really tier our flow of patients to prevent folks becoming exposed to those infected, it really, really impacts not just the hospital, but the community. So for example, telehealth is a big one for us. The other one is to make sure that a lot of folks don't show up into our clinics at the same time, to strategize that they come in at different times to keep the volume low. We also want to talk about the emergency department. Really, we use our testing center for those that are coming in to be tested without symptom, the asymptomatic carriers and so forth, to keep the ED just for those that are ill. And to also, from inside the hospital, one thing we found out that worked really well, and we were, I think, ahead of the curve, was that we expanded as the number of patients coming. We had the ability to expand, to open up new COVID units or new units that were patients under investigation for COVID. And by doing that and keeping these patients separate from the rest of the community in the hospital, we were able to really control any type of inherent spread in the hospital. And that we definitely, found to be advantageous. And so I think we are much better prepared. And as we follow the treatment options, which I don't want to forget, and you heard Dr. Ferguson mention it about that huge inflammation surge that happens that causes all the other chronic disease to become active. We now know we are in multiple trials, but we also know which of the trials seem to be helping the most. those that control that inflammatory response, such as the high dose steroids, such as the remdesivir and things like that. Those we are in the trials, but we also are putting it to good use to serve our community.
Doctor, thank you so much. Dr. Smith, you're an oncologist and you provide care to patients with cancer. Give us your perspective about how the pandemic has affected your patients.
Yeah. Well, like others have said, thank you for including me on this panel. I'm honored to be here. I think there are several important things that happened to cancer patients during this pandemic. First, we know that Blacks and Latinos have poorer outcomes throughout the trajectory of cancer care, from screening to diagnosis to treatment to survivorship and then out through the end of life. A model created by the National Cancer Institute predicts that tens of thousands of excess cancer deaths will occur over the next decade as a result of missed screenings, delays in diagnosis, and reductions in oncology care that have been caused from this pandemic. You know, cancer delivery really had to change in numerous ways. So not only are patients not getting their screening in a timely and appropriate manner, patients are getting cancer treatment that has to have been modified to non-standard treatments. You know, unfortunately, these changes will impact communities of color even more and widen the disparities that we already know exist. I think we've also seen the rapid adoption of the use of technology and telehealth to care for patients during this pandemic. In the ambulatory setting, certainly video visits and telephone encounters were utilized to keep patients connected to care, yet we know a digital divide exists, which encompasses the absence of technology, digital literacy, and reliable internet coverage among communities of color, which just further compounds the disparities that exist. You know, I think it's also fair to mention that these methods, specifically video visits and telephone encounters, were not typically reimbursed at similar rates to inpatient visits, which ultimately puts a strain on the healthcare system.
What do you think you want individuals, particularly communities of color and other vulnerable populations, to be aware of when you're accessing care?
Yeah. So I think the most important thing to know now is, at least particularly within New York, the hospital systems are doing and medical centers are doing all they can to really mitigate risk to you and to your loved ones to decrease the risk of COVID-19. And it's important to seek care. It is as safe as it is going to be, and you really need to focus on your care at this moment.
Yeah. Thank you, Doctor. Dr. Dignam, how is VSNY supporting African American and Latino communities in New York City to stay healthy? And in what ways does VSNY address access to healthcare services?
Thank you, Bob, for this question. And again, I would like to thank everyone and also our listeners today in this very important conversation for our webinar. Thank you for your attendance today. To support the African American and Latino communities in New York City and other minorities, as well as the vulnerable populations, VNSNY has many ways to address healthcare disparities and provide access to healthcare services. As a background, VNSNY established 127 years ago as a nonprofit community-based organization with its mission and legacy to address the needs of immigrant and multicultural communities. It is our goal to keep our patients at home, surrounded by their families and loved ones. I'd like to highlight some of the ways we support these communities of color as follows. First, VNSNY understands the importance of culturally sensitive and patient care-centered approach. Serving the unique needs of all our patients is a priority of our organization. We were the first home and community-based provider to launch multicultural programs to better serve our diverse community. As Andrea has mentioned earlier, we have services across the continuum of services, such as home care to end-of-life care, chronic care management, as well as behavioral and mental health services, and providing end-of-life care and hospice. We provide training not only to our VNSNY employees, but have trained many of our partners in providing cultural sensitivity care to vulnerable populations. Our HOPE program that is being highlighted today provides training and providing culturally sensitive end-of-life care to African American and Latino communities. Secondly, another way to increase healthcare services and reduce healthcare disparities, we recruit and build multicultural workforce who reflect the communities we serve. As previously highlighted, a big barrier to care is language, lack of cultural sensitivity, and often a lack of trust. VNSNY addresses these barriers by hiring staff who reflect the community, share the same cultural background, and therefore help build trust. At VNSNY, our staff reflects the diversity of New York City. Collectively, our staff speak over 50 languages, and we do our best to provide a clinician who speaks the patient's preferred language and understand the religious and cultural traditions. We also hold focus groups within our internal teams from different ethnic communities to gain insights into the healthcare needs and cultural preferences in their communities. Third, to enhance the customer experience, we provide educational materials, both written and verbal communication in patients' preferred language, so we can educate patients, caregivers, and families on their medical conditions and treatments to make sure they understand their care options and can make informed decisions. Our staff have access to a translation service when needed. Fourth, VNSNY, we partner with key stakeholders in the community to educate them on home care and hospice options and to create easy access and linkages to care. We identify hospital systems as our key partners, key physicians, federally qualified health centers, hospitals, as I mentioned, housing sites, social services, community organizations to reach out to these vulnerable populations and communities of colors. To help our minorities, we also provide our referral partners in those communities with brochures and materials in multiple languages. And we also join our partners and participate in community events and initiatives to increase awareness in those communities. To sum up, Bob, as you can see, VNSNY is a leader in providing culturally sensitive, patient-centered care throughout our continuum. As the communities of New York City continue to change, so does the diversity of our VNSNY leadership team and our workforce. Again, addressing health disparities, access, and being a leader in providing culturally sensitive care is a top priority for VNSNY. Yeah. Thank you.
And you know, African Americans and Latinos are more likely to die in a hospital setting and receive aggressive treatment instead of choosing comfort care at home, which hospice provides. Why are so few people in these communities choosing hospice? Can you comment on the barriers also to enrolling in hospice and discuss the role of the advanced care planning?
Thank you, Bob. That is a great question. As we have learned from multiple studies, as well as highlighted earlier by my co-panelists, there are racial differences in aspects of end-of-life care with ethnic minorities and are likely to be less engaged in planning activities for end-of-life, hence more likely to die in hospital setting compared to white Americans. As already mentioned earlier, reasons of underutilization of hospice can be attributed to different cultural values, lack of knowledge of hospice services, mistrust of the healthcare system, socioeconomic status, lack of health insurance, lack of culturally congruent staff and language barrier, family culture, and religious beliefs. VNSNY has recognized the low utilization of hospice in African Americans and Hispanics and launched the HOPE program several years ago, approximately about 5 years ago. HOPE stands for the Hospice Outreach Provider and Patient Engagement. It is a program to increase awareness of hospice services in African American and Hispanics and help improve advanced care planning and end-of-life care. In 2017, the National Hospice and Palliative Care Organization showed 82.5% of the Caucasians utilized hospice care compared to 8.2% in African Americans and 6.4% in the Hispanic. In 2019, in VNSNY, we served more than 6,000 hospice patients. With estimated 27% of patients have languages other than English as their primary language. Estimated 50% of patients were Caucasian, 21% Hispanic, 18% African American, and 12 were Asian. I think what we learned is that with outreach, programs such as HOPE, education, and partnership with key physicians, healthcare leaders, and stakeholders, as well as the faith-based organization and community, we can drive the change and increase advanced care planning. For example, the way we work with Harlem Hospital, with Dr. Wright, with the Mount Sinai teams, and working with the NYU in their advanced care planning initiatives, such as the EMOLST implementation and training in respecting choices, and with many physicians in the 5 boroughs, one African American and Latino family at a time, we are educating and increasing advanced care planning and improving end-of-life care.
Dr. Dignam, thank you so much. All right, let's put a wrap on this. It's a very important discussion. Let's wrap it up with identifying solutions for improving health access and addressing disparities. Doctors, what's your vision for creating a better healthcare system that is responsive to communities of color and other vulnerable populations? Do you have a call to action?
So this is Dr. Fergus. So first of all, Bob, we cannot hope to, experience change across the entire community unless we reach out to our younger members of the community and the entire extended family. So in this discussion, we've spoken a lot about probably what affects mainly adults and, older generation. So I submit to you that we have to get the message out to the younger, the children, our students going back to school, getting them to understand, getting them to really care, because again, they are carriers of COVID-19 potentially. They may be asymptomatic and they may bring it home to others who are more susceptible. But we also know that some of the young themselves may become, ill and die. And when that happens, it's catastrophic. So one of the things that I've done is I've created a program within Central Harlem that's called the Healthy Heart Series, but it really deals with across, all of the chronic conditions. And one of the things, I'm writing a grant to provide a COVID toolkit, to provide a pulse oximeter, thermometer, mask, and some reading materials for each person who needs that. Because as I think Dr. Wright pointed out, or maybe one of the other doctors, that, some of the patients had a low oxygen level. And unfortunately with this virus, you may be walking around with an oxygen level of 90% or less and not even know it. But at a certain point, you become confused, you pass out, your respiratory system fails. So having the appropriate tools to be able to address some of these issues, physically and tangibly is important. One of the things I did, Bob, was I wrote this book, okay? And it's geared towards the younger members of our community, and it's called Rona, You Are Not Welcome in My Body. It's coronavirus explained for little ones. And it has kids from the community, but it describes coronavirus, the mechanisms by which it attacks people, but it also provides, pictorial example of what example is this virus, what exactly is it, how it affects you, but it also provides interactive feedback. It shows them how to look at chronic conditions that may, that may be present and how to deal with it. So for instance, on this page, it goes, stop corona in its tracks, avoid unhealthy living. And then it tells you avoid stress, junk food, soda, not enough veggies, and lack of exercise. Because a lot of these kids stayed in their rooms and they played video games. And even though they may be able to go out to the park or whatever, they weren't doing that. So, it's important to just get these little pearls of information out to the community if we're going to be able to move the needle.
Yeah. And how does one pick up that book?
This book is, you can reach out to Michelle Drayton. And I'll be happy to provide this booklet, and then we also have some online access to it as well.
Oh, great. All right.
Bob.
Any other doctors?
Yeah.
Dr. Wright?
If I could chime in here. So here, Dr. Ferguson talk about these behaviors. But one of the behaviors that is bothering me now as I walk through the community, it doesn't look like a few months ago when everybody was scared and keeping their distancing and doing all their face shields and, cleansing their hands. And we have to, that's a continuous call to action. I am scared deadly about what I'm seeing now compared to a few months ago. The behaviors are getting very, very lax. The disease, although, the virus is down to a low percentage, it's still here. It's still very, very virulent. It puts those at risk, at even higher risk when you contract it from an asymptomatic carrier and don't even recognize you have it and assume that it's not around. So that's one. The second one is for us on the healthcare side, and that is in providing care to patients to educate them so they can educate beyond our walls. I just came off service. I had a bunch of residents with me, and I kept telling them, find some time to speak to your patients. They didn't come for this, but you do not want your patients with hypertension, diabetes, chronic kidney disease, and so forth, going home without this information. So another call to action is to educate all those that we encounter so they can also be our extenders to educate those beyond. So those are two very, very important ones I think we have to add to the bucket.
All right.
Excellent.
This is Dr. Delmont. As representing a group of independent doctors, I think that my call to action would be, first of all, reassure the outpatient space that telemedicine reimbursement will remain in order for us to be able not only to care for patients during the pandemic, but beyond. It's definitely proven a model that we necessarily didn't feel comfortable with, that we were sort of forced into it because of the situation of the pandemic, but maybe taking a step back, understanding really how does it fit within our workflows. We have significant issues of staffing right now because of so many of our staff members that were ill or were furloughed. So doctors need to reevaluate their workflow, and we need to connect with our patients in their space, understanding that they prefer in many instances to take telemedicine visits because they save on transportation, they save on inconveniences, they may not have to miss a day of work and they don't get paid if they don't work. So looking into our workflows and being prepared, God, for hopefully it never happens again, but even just handling any type of wave or resurgence of the existing pandemic, that we are prepared to communicate better with our patients and meet their needs, and as you mentioned, also educate them so that we continue preventing new cases.
Thank you.
I think for me, I have two main calls to action. I think to expand upon the prior point, we really have the ability now to re-examine policy and payment structures that focus on increased access to telehealth. One of the things we were able to do here in cancer is to obtain a grant from the FCC to use remote monitoring devices to care for patients in their home. So patients will not only have a device that will be measuring their vitals, pulse ox, blood pressure, temperature, pulse, but they'll also have tablets provided to them in the home so that they can do video visits with instructions in both English and Spanish and working on other languages. And this will be important to monitor them safely from their home should we have a second wave, and certainly if they should develop COVID. And then lastly, I would say if this has taught us nothing, it has taught us how much the social determinants of health are crucial to these communities. And we have a real ability to be able to screen patients and to processes in place and community organizations around patients so that they can really get the care that they need.
Excellent.
Hi, Bob. Yeah.
Go on.
Hi, Bob. Yeah, it's Dr. Dignam. For me, I mean, to help improve healthcare access, including planning for activities and end-of-life care, for my call to action, we should continue to address advanced care planning in New York and improve hospice utilization. New York State ranks 49 in the country in hospice utilization compared to other states. As New Yorkers, we need to do better. COVID-19 pandemic hit us. Many died, and many died probably alone in the hospital systems. And likely many of our vulnerable populations still may not have advanced care planning in place. VNSNY cannot do this alone. We need you. Right now, we probably have over 250 people dialed into this webinar. If each one of you can go back and talk to 10 people about advanced care planning and promote access to quality end-of-life care through hospice, that is about 2,500 that will hopefully now be aware of the importance of advanced care planning. So let's continue this conversation, work together, and make it happen. Thank you, Bob.
All right. Thank you, guys. Anybody else? Okay, we may have some questions from the audience. Sherry, do we have any questions that are posed by the audience?
We do, Bob. We have one question, which is a very important question. A person would like to know about how to manage stress levels among Black and Latinos, particularly those in healthcare. Who would like to take that question?
Hi, this is Dr. Dignam. I'd like to take that question. Thank you so much. That is very, very important in the time even before the pandemic and during the pandemic. And I think accessing community-based services or even in-hospital services, I would say probably importantly in the outpatient setting, like VNSNY, for example, we do have our behavioral and mental health program that can be accessed and provide services to really, to care for this stress and address the stress in the community.
And if I may add to that, it is well known that Black women in particular have unrecognized stress. They're often, dealing with family members, their kids and themselves, and particularly try to be at the same level as recognized at, other individuals within the office. There's a great paper that is circulated by Harvard that was, printed about 2 years ago that dealt with, work stress. So imagine that this is now compounded by, dealing with the pandemic, et cetera. So I would say to you, recognize if you're the individual that you have the stress and address it. And if you're an employer and you're in a position to deal with this, people may not come to you because people don't want to be perceived as being weak or not complying to the norm, but provide an opportunity for people to one, express themselves either with an anonymous box and or provide services that people can go to anonymously to get some sort of, support and, guidance. The other thing I could tell you is that stress is mitigated by exercise and movement. So if you're not willing or able to seek out, professional care for your own self, there are things that you can do, such as meditation, Tai Chi, Reiki, but exercise, movement, all of those, they increase your endorphins, allow you to relax, and hopefully be able to deal with some of these stressful, events. So I see Dr. Bob doing some stretching. Yeah. Find some downtime for yourself. And if you're in the position to do that, make sure that that's available for your employees or people who work for you, or, provide these options and suggestions for members of the community.
Thank you, doctors. We do have one more question here, and that is what the ongoing plans to strengthen healthcare partnerships within the communities of color to improve the system. Who would like to address that question?
Let me take a shot at that one. We are really in a different sphere now of communicating with our providers and our healthcare partners in the community. Let me take the first one. For example, if you show up to the emergency department and we identify you as probably low risk but undergoing stress, we have many, many partners in the community that we refer to. We actually give you your choice and we arrange for you to be seen in those environments. We can also do it at the hospital. We partner with our local providers about their patients. So if their patients show up to our doors, we get to them really quickly so that we can communicate what's going on for care once they leave our facility. That is becoming more and more evident as the chronicity of some of the syndromes that are related to COVID now are beginning to be seen. And the last one I'd say is that the partnerships that we have with some of our payers in making sure that folks get access to care wherever they seek it is getting better and better. So I think things are moving in the right direction, probably slower than I would like at times, but it is moving. And I'm grateful to see some of these moves.
Thank you, Dr. Wright. And we'll take one last question here, and this is probably a quick one. Flu shots, when is the right time to get a flu shot? Who would like to take that?
Starting now.
Now.
Please, 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 starting now, immediately.
Yeah, the last thing we need is a bunch of people with fever and not knowing if they have COVID or something else. I mean, if there was a year to get the flu shot, it's this year.
Yes, and I think we need to really heed the campaign of getting the flu, doing the flu campaign in both inpatient and outpatient settings, home care-based, community-based organizations as well.
And I wanted to include that something else that we need to learn, for example, with all the testing sites at Somos, is really that we should be using similar platforms in doing outreach for preventive medicine instead of this situation of the pandemic. So we're revisiting, how the success that we had with testing and using this for more formal campaigns that could, an example would be the flu vaccine, and just like other preventive screening, and how effective it was collaborating with many people from the community to get our populations access to care.
Okay. Well, thank you guys so much. Thank you, Sherry. I'm going to turn it over to Andrea Castellanos. She is the Executive Vice President and Chief Provider Services for the Visiting Nurse Service of New York, and she has a special introduction. Andrea?
Thank you, Bob. And thank you to all of our panelists today. The one thing I am certain of is that I want all of you on the panel to be my personal doctors so that your empathy, your brilliance, your futuristic view of how to address and tackle these complicated issues are really, it's really exciting to hear all of your thoughts and ideas. So thank you again. So the man I'm about to introduce has dedicated his entire professional career tackling racial and social inequities impacting underrepresented minorities. He has had an extraordinarily positive impact throughout the years, and I know he will continue to be a strong advocate as we move forward. It is now my pleasure to introduce Congressman Adriano Espaillat for some closing remarks. Congressman Espaillat is the United States representative for New York's 13th Congressional District and is the first Dominican American member of Congress. He previously served as a member of the New York State Senate and as a member of the New York State Assembly. He was the ranking member of the New York Senate Housing, Construction and Community Development Committee and Chair of the Senate Latino Caucus. Congressman Espaillat, thank you for joining us today.
Thank you so much. I want to thank the Visiting Nurse Services of New York for hosting this wonderful summit and to bring together so many of you, including the Somos Community Care Network and our local officials and esteemed members from both Harlem Hospital in my district as well as Mount Sinai Hospital, both in my district. I happen to represent the district that has perhaps the most numbers of hospital beds in the country, with Mount Sinai and Harlem Hospital and Metropolitan Hospital and New York Presbyterian Hospital, as well as Montefiore in the Bronx, Northwest Bronx Hospital. And so we have a great number of health institutions that were critical during the pandemic in providing life-saving service to many of my constituents and folks from throughout the city and the country that came to those institutions to save their lives, basically. But it wouldn't have been possible without the great network of support that exists in the district and in the state. And that, of course, includes the Visiting Nurse Services of New York, which have a long-standing history of providing such great service for communities across the state and particularly in my district. And it's great to hear from you, Dr. Derman, and Dr. Icy and Dr. Smith and Dr. Wright, all representing very important community partners and leaders in New York City. During this pandemic and the worst month, I worked with each and every one of you in making sure that we helped out to make sure that our patients and my constituents got access to testing and treatment that they needed. I remember the first test site that we opened up was in the Bronx with Somos, and it was right by Lehman College. And I believe that over 50,000 people were eventually tested there. And so that's so critical, so important to my community. And this entire episode, since the public health emergency began in March of this year, has made it clear before our very own eyes that disparities exist. Now, we knew that for a long time, but now the rest of the world knows that people with diabetes, people with high blood pressure, with respiratory diseases, with cardiovascular problems have a bull's mark in their back. And those were the folks that fought for their lives in different hospitals and health institutions across the district. Underlying chronic illnesses and diseases impact in so many ways, and COVID-19 made that very evident. So I want to thank you again for the work that you do every day, what you will continue to do. Harlem Hospital, Mount Sinai, Sydenham, where there is I remember opening up a testing site there. We must continue to test, trace, and treat, the TTT, right? The triple T, test, trace, and treat those patients that are positive. And this is not over yet. So I know that you are still very much cognizant of what may occur again, and you will be once again there in the trenches for all of you. I do want to thank you from the bottom of my heart for all the work that you did with our community, with our local doctors. You worked hand in hand during the most difficult days that I've ever seen across my district. And of course, we did get hit very hard, but you made it so much better. So thank you so much, Visiting Nurse Services of New York. God bless you and keep the faith.
Thank you, Congressman Espaillat, for your support, your encouragement, and your powerful words of hope as we move forward. I'm going to turn it back to Bob for some final closing remarks. Thank you, everyone.
Thank you, Andrea. Thank you, Congressman. All right. I want to thank everybody for letting us share in this space and time with you with the Visiting Nurse Service of New York, Project Hope, Physician and Health Leaders Summit, caring for communities of color and other vulnerable communities in a global pandemic, lessons from the front line. And to our front line, risking their lives and sometimes losing their lives to go on helping us go on and live out, our lives. Thank you, thank you, thank you. For all of us here at the VNSNY, have a great and special day. We love you all. Bye.